Okay, well, welcome back, everyone. What I'd like to do today is to take us to the next step in what we've been doing in CBT T. Remember, I'm not trying to be precise about exactly what session most things will happen in because people differ in their reactions. Some people are very quick to get to behavioural experiments, phase 2. Other people take a bit longer. But what we do have is one set point, which is session 4. This is the point where we review progress. It's kind of a bit like the taking stock thing in CBTE, but much sooner, based more around the evidence that we don't want to keep people going if the therapy hasn't got a chance of being effective. And there's reasons for that, which are actually about the patient's benefit, not just about ending therapy for the sake of ending therapy. So I'm hoping this stuff will make sense. Please do ask questions, though, and please do stick your hands up about it. And I'll talk about what we do during the skills practice later on. Okie doke. So let's kick off. I've now got everybody for the register. Hooray! I feel really, really good about that. Because normally, as I say, incompetence is my friend. Right. Okay, reviewing progress and then shifting from the exposure phase to the behavioural experiment phase, or what you need to think of being dealing with the sheer bloody terror of trying to eat differently, to dealing with the logic and the cognitive side of eating differently. So today, sorry, Amanda, the last couple of you in, I think you and Natasha, there is no code for today. But I've already ticked you off on the register that Rachel provided. And the same will happen this afternoon in supervision. So don't panic, you don't have anything to put in today. Right, yes, reviewing progress is the first part of what I want to do up to the coffee break. And then, okay, for those patients who are doing well, and it will be the majority by quite some distance, what we do in phase 2 with behavioural experiments. That's the goal for today. Because what I'm trying to lead up to is getting as quickly as I can to the emotional work, to the body image work. We'll be starting that up very shortly. So next week we'll start moving on to the more emotional work. I do want you to be thinking, is this patient engaging in therapy? Am I pushing the patient hard enough that they are going to end up thinking, okay, yeah, I'm doing well here. And if I'm doing well here, I could do well with the rest of the therapy. Right, let's try moving on here. If I can find the right button. Yeah. Okay, so quick reflection on workshop number 2, the session we had last time. And then I'm going to move on to reviewing progress, deciding about continuing therapy. And then after the coffee break, behavioural experiments, examples of those key skills, and a bit of a chance to reflect on things you pick up from today. It's worth remembering, of course, that again, as with exposure, there isn't an explicit focus on behavioural experiments in CBT. So I'm going to be talking about the structure of behavioural experiments, hopefully the kind of thing you remember from your CBT for anxiety and depression, but it won't reflect what you had with CBTE. It's part of the difference in the patterns of the therapy. So what I want you to be able to do is to make rational, patient-focused decisions about whether to continue the therapy. Not just, oh, they're not doing it, we're going to kick them out, but decisions about what to do that are about helping the patient do well in the medium, short, or long term, depending on how they're prepared to buy in. So you can try them out in future treatment. Then after the break, develop behavioural experiments, reviewing the outcomes. You might have started this around session 3. It's very rare to see in session 2, but session 3 maybe session 4, 5, that kind of area. And these will continue as you go along, even while you're doing the emotional work, the body image work. You might still be helping the person realize that, for example, cake is not the big enemy in the world. And again, all the way through, thinking about the individual patient. How do you adjust it for the person in front of you at the time? So that's a broad learning objective for today. Before we get going though, I just want to take people back to last time because I was talking about that inhibitory learning model of exposure. And what I'm interested in is, did anybody have any kind of immediate reactions to that? Has anybody tried it out? Does anybody have any thoughts about how it might or might not work in their service? So any thoughts about last time from anybody? Just stick your hand up. Okay, I'm going to assume that that means you all understand it perfectly, which will be lovely. But do come back to it if there's a little bit in your head that's saying, oh, maybe I'm not totally on top of it, because you're allowed not to be. All right then, reviewing progress. Now, this is session 4, but you better not just start doing this at session 4. This is something you need to have the patient onto from session number 1, and all the way through those first few sessions. And it's about the empathy plus the firmness. Really, really want you to get well, really want you to recover. But that means that we need to be sure that you're actually making some movement. Because if you're not making any movement, you're going to be in trouble. Because I think I've already talked to you about the sheer number of therapy sessions that some patients have where they're not making any change at all. And the therapist just keeps on going and keeps on going. So what's the goal of session 4? Number 1, and this is the great majority, keep the patient in therapy, encourage them for the future part of treatment. That's my number 1 goal. I really want to do that. If they're not doing well in therapy, if they're not engaging in it, then getting them back to engage in it. I want session 4 to be a real, oh shit, he really means it moment. Because if we want people to get well, whether it's long or short therapy, they need to make change early on. Do you remember I talked to you about this one, the evidence base around how early change is absolutely critical to people's chance of doing well. They don't catch up, etc. So if I need to push them at session 4 to engage, then I'll do that. And then the third option, and far and away my least preferred, but still an important one to actually put into action for some patients, is end therapy at this point and either think about another therapy or think about come back when you're ready to engage in a therapy. Because one of the problems we have is services that say, oh, they're not doing well with that therapy, try them with another one. And they're not doing well with that one, try them with another one. And you have the same person being moved through 3 or 4 different therapies. And the common theme after maybe 2 years worth of being in therapy, the common theme is the patient isn't engaging with it. You remember, from the patient's point of view, you guys might be the loveliest person they see all week. You might be their quiet moment. And coming to see you is probably very, very nice indeed. But if they don't want to change as well, then you're going to be in trouble. Because eventually it's going to get to the point where you run out of air in the therapy. Now, if I'm teaching this stuff in person, I will normally ask a question at this, which is, have you ever had a patient where you just sat down one day and thought, wouldn't it be nice if they just didn't turn up today and I could discharge them? If you've had that experience, and from the smiles around the room, I'm thinking quite a few people might have done, that means you've held off that patient too long. And I've done it plenty of times. I've sat there and I thought, where the heck am I going with this patient? But of course, nothing has changed in the way they're doing things. So it feels really rude to say, actually, we're not getting anywhere, let's stop. Because that moment passed some time ago. So what session 4 is about getting you to think, okay, got to actually do this before it becomes the case that this patient is just not there. They're turning up for therapy, they're in therapy, they're not doing therapy. So my three options. Number 1, I'd love to keep the patient in therapy, get them active, more active, encourage them to do well. I'll kickstart things again for them if I need to, or if they absolutely don't want to get engaged in change, then it's time to say, okay, then we can't do anything at this stage, let's stop. So that broadly speaking is what we're aiming at. But again, with the emphasis on the, I'd like to be at the top of that pile, if that's okay. So what do we do in session 4? Just going to take you through the kind of core tasks, a lot of which hopefully by now you're familiar with, things like diaries and weighing the patient. But we put the review right at the beginning, as close to the beginning as we can after we check for safety, weight, etc. And the reason for that is either I've got to do a lot of kind of rebooting therapy, or I need to do very minimal rebooting therapy. I need to get the patient out there doing their stuff, or we can move on to behavioural experiments, and who wants to waste that time? So we've got the usual stuff. This is the stuff I know that you're all great with, etc. You understand, you greet the patient, you set the agenda, you review the questionnaires, you review other homework, you look at risk, you address the therapeutic behaviours, which get less and less over time. And then you review the diary, you weigh the patient, chart the behaviour, you wind up the session, you set the homework. Hopefully that's a fairly familiar generic agenda. And some of it will be relevant at this early stage, some of it gets less relevant as you move along. Okay, that's the stuff I don't intend to go over with you every week. The stuff I do want you to think about, though, is how we manage whether the person's doing well. So remember, this should not be the first time you talk about session 4. That should be in session 1 and in session 2 and in session 3. But what I really like about session 2 and 3 is to be able to say to the patient, you've done really well. I think session 4 will be an absolute breeze if you keep going like this. Or, okay, you haven't made much change. And remember, we've got session 4 coming up. So your time is getting really tight to actually make the change. Anything like that that gets the patient aware that the clock is ticking is a good way of keeping them on board with the possibility of change. They may decide they don't want to change, and you'll learn that earlier with this than you would with CBT because you've got the earlier review point. So what I'll do is I'll look at the past week, I'll look at the diaries, I'll weigh the patient, I'll look at the measures, and if all is going well at session 4, then brilliant. This will be one of the shortest, most, if you like, insignificant elements of therapy from your point of view. So it'll take you 5 minutes. From the patient's point of view, though, it could be quite a relief. Our patients worry, am I going to pass the review at session 4? I want them worried like that. Sorry, I know I've told you before, I'm quite good at tolerating my own anxiety about getting people worried, but I want them worried at session 2 and 3, whether they're doing it, because that will keep them on the ball. So what are we doing? We review the progress, we look at how the patient is doing, I'll come to the criteria for that in a moment, and we're either going forward with no delay, the 5 minutes, and we'll get on with the behavioural experiment maybe. We might stop appropriately, or we might go for the one last chance option. This is the, if you like, kickstarting therapy again. I'll put it in inverted commas because that's how I present it. Okay, you've got one last chance to do this, otherwise we need to stop. I'm not a great fan of just saying to people, you failed, get out. I'd much rather say, this isn't working, we need to stop, unless we can make it work, but you haven't been doing that. I want the patient, and it sounds very dramatic, I want the patient saying, please let me have a go. I can remember a number of patients over the years who said literally, I didn't know you were serious. I know you said, we'd stop if it wasn't working, but I've heard that before, it's never happened. I want them to have a real shock about that one, which is why I tried to foreshadow it in the previous session. And whatever method we're using to try to go forward, we're going to start maintaining and extending those eating patterns. I want the patient going out at the end of session 4 going, okay, I can do some more exposure, but now it's time to start learning about the safety of eating. Do you remember I talked before? Inhibitory learning, we want people to learn safety, not unlearn fear, learn safety. So now we need to start helping people learn that that particular food is okay, or that particular way of eating food is okay. So that's where we get to the behavioural experiments. Um, this is where we hit motivation, isn't it? Because I'm sure every one of you has had patients who have said, I want to be, or if, said or acted like, I want to be in therapy, but I don't want to change, which of course is a bit of a misnomer about what therapy is. Yeah, we're not here to keep seeing people for 25 years, like Woody Allen's psychotherapist. We're here to get people to the point where they have a life. And usually you'll see in the first couple of sessions, it's the patient's motivation conflicting with the therapy. Now, I'm going to start with number one. I have to lose weight now. Hopefully that's fairly familiar to you. There's probably a fair chance you had a patient coming in saying, I just started these injections and they're helping me lose weight, etc. Any attempt to lose weight is going to mess with the therapy for the disorder. We will work around it with diabetes, but that's pretty much the only time that we can do that. And there we might even be saying, okay, get the weight loss done, and then we can focus on the binging. The problem there, of course, is if you keep binging, your weight loss doesn't really happen. So we have to think, okay, how are we going to manage this? Now, there's different ways of dealing. Let's imagine we've got the patient who says, I've got to lose, I've got to be on a diet now. You've got to help me lose weight, or I've got to lose weight now because I've got a wedding coming up, or I've got a holiday coming up, and I can't possibly risk gaining weight, or more importantly, I've got to lose at least 12 kilos to get into the dress, whatever it might be. And it's, of course, I think everyone here will know, all weddings happen 2 weeks after you start therapy. I don't know why, but it just seems to be, oh, I've got a wedding in 2 weeks. Okay, yeah. Can you help me lose 5 kilos, between now and next week? No, not really. It's that desperation. I totally get it, it's desperation. What we have to do is help the patient not rely on the desperation. So let's say I've got a patient who walks in, they've just started taking a semaglutide. Has anybody had that experience? Just stick your hand up if you've got a patient who comes in saying, I want to deal with my eating disorder, but I've just taken these jabs. Does that sound familiar to anyone? Yep, Helen. Yep, there's a few of you in there with hands popping up. What I'll usually say to a patient under those circumstances is, let's not just say, well, look, therapy can't work that way. Off you go, come back when you're ready to do therapy. What I'll do is I'll say, okay, let's have an experiment here. This will have been session 1 or 2. Let's have a bit of an experiment here. You do it your way for a month. If it's working, brilliant, absolutely brilliant. Pat on the back, well done, you've solved your bulimia. The problem will be, of course, with the jab, that you may well lose the weight up to the point where you can't afford the jab or can't get the jab anymore, but then it's very likely to be coming back. I think the rate at the moment is something like 80% of the weight is regained within a year of coming off the medication. So, I'll say to the person, the problem here is you've picked a way of solving one problem, but you're not actually solving the problem of loss of control. So if your emotions are because you're starved, if your binges are because you're starved, if they're because of emotional factors, those are going to come back. And that's why you're likely to end up regaining the weight. You could do therapy then, or we could say, tell you what, do the therapy now and then decide if you want to be on the jabs. And that can be a real shock to patients, that you could do the therapy now. As I say, the only group I'll work with very clearly while they are taking jabs is diabetes, diabetes where there's real physical risk from the overall obesity. My favourite way of dealing with this would be, let's say, I don't know, Trudy comes to the door, says, I want to get this sorted, but I'm taking these jabs, or I'm going to go onto a diet right now. I'd say, Trudy, you go do that. Come back in a month, tell me how well it's worked. If it has worked, I'll pat you on the back, I'll say, well done. If it hasn't worked, if you've gone back to binging, then I'll be saying to you, okay, let's try it a different way. Let's try a way that has got their chance of being effective for you. Um, and that's about teaching the person that the thing they dream about, yet another diet, isn't effective. It's just our job to make sure they get a chance to try that. So we have a conversation that isn't based on we are frustrating you, it's your body can't handle it. Cara, go for it.
Oh yeah, I was just going to add to what you said there, Glenn. I did have a patient that did CBT T, and then she went on to do the Manjaro. So she did a little bit sooner than we advised, but her BMI was like 60, 65. So she was really feeling quite desperate health-wise. So it just showed, she said, how the therapy was really helpful before, and that helped her then do the weight loss injections much safer and in a much more sensible way.
Yeah. And that's a really good example. You get the person to the point where they're in control of themselves, and then you take the medical route for dealing with the immediate risk from weight. I'd say that sounds like a perfect way of doing it. I mean, I've never tried the jabs, but I'm told they completely wipe out any real desire for food. But if she doesn't have the desire based on I'm starving myself, then hopefully when the jabs do come up her regime, she'll be able to say, okay, now I know that I need to eat regularly. So was that the general goal, Cara?
Yeah, she still kept regular eating,
Yeah.
but obviously reduced the amount because of a high BMI. She really, she had quite a large appetite, and she started on the lowest dose. So she did it by a pharmacy, so that, like, they started on the lower dose anyway, which helped. So it's very gradual. She kept on doing a bit of activity, and so she even had a bit of dietetic input before anyway, just to make sure she has that mix of groups and to keep going with that, sort of keeping it so she doesn't starve herself, basically, like you said.
Yeah.
Yeah.
That's great. I think that's really good. And it might take 2 or 3 years to get a weight down to a point which is much less of physical risk. And it could take her many more years to get down to a weight where she's in the normal range. But you've helped to get to the point where she's not binging and hence pushing the weight upwards at the same time.
Yeah, hopefully it's going to really help her health, because she did struggle because of she was quite young, but she even struggled with joint pain because of her BMI. So
yeah,
I'm hoping it's really, from what she told me, it was really nice because she managed to sort of work on some of the emotional side and the regular eating as well.
Yeah, and that sounds like a really good example of how we build up quality of life for people. We get them to the point where they're not pinned down by the safety behaviours, by the eating problem, etc. So really pleased, that sounds good. Okay, moving on a bit. How do we handle the progress or the lack of it in session 4? Now remember this little diagram down here, hopefully. Remember, patients who make very quick change have a higher recovery rate and it stays higher later on. People with a more moderate gain, again, you'll see some recovery. It's not as high and it doesn't catch up. And the people we want to avoid being are the therapists who promote very minimal change, because that tends to go away completely. So what I want you to get used to is thinking fast change gives you the best possible chance of helping this patient. Then you've got to communicate that to the patient, which is why I actually will use this kind of graph. Draw it out on the whiteboard at the beginning of therapy and say, okay, I want you to be on that purple line because that gives you the best chance of getting out of this problem and staying out of the problem. If we don't change much at the beginning, there's a very strong chance you'll still have the problem at the end. Okay, so be prepared to talk to your patients about general cases based on the research, but it really is quite depressingly consistent across the literature. So we're in session 4, we're close to the beginning. Can we see real consistent change? Now, don't make the mistake of assuming I want to see perfection here. I don't. If a patient can be perfectly cured within 4 sessions, we'll call it CBT 4 and have done with it and walk away there. What we want to see is enough progress that the patient thinks, hey, I can do this. So I want enough material that the patient can feel motivated about and that I can encourage. Look what you did there. Look how well you've done going from that to that in just a couple of sessions by making that change. So we look at DD15, saying what changed, linking up the behavior. But I'll be doing that every time anyway. What I really want to be able to do is that session 4, say to the patient, let's look at your eating pattern, let's look at your diary. Wow, look, breakfast, that wasn't there before. Lunch wasn't there before. Binging isn't there, it was there before. Remember, the great majority of the binges will go by session 4 if you're applying the exposure element correctly. Not for every patient, there'll still be some emotional ones, so I'm not saying get rid of all the binging. But I want to see a good change in the patient's buy-in to eating differently. Now, I was doing some supervision yesterday, not with any of you guys, but the clinician was saying what happened was for 2 sessions, the patient did wonderfully. This is an anorexic patient, did wonderfully, and then they stopped because they thought, oh, well, that's it. I don't have to try anymore. We have to keep the patient thinking, I've got to keep trying. So I'll look at the diary. I'll look at the eating attitudes. I'll look at the ED15. I'll look at the EDEQ. I'll look at the log of behaviors. I want to see, is the binging coming down? Is the vomiting coming down, etc.? And are there still some behaviors which are there, which are more emotional in nature? Remember, our patients differ. We're doing the exposure work first to get stability biologically and to help the patient feel, okay, I'm on top of it here. Biologically, I can manage it. There will still be emotional factors for some people. So session 4, I'd like an idea, if you're still binging a couple of times a week, but you've made all these changes to your eating, etc., what's going on up there emotionally, cognitively, that's triggering those binges? That is why we're going to come on to that next week. Okay, we're going to get onto emotions next week because it's going to be really important to get people aware of what the emotional factors are and how to step away from them. So we take 2 weeks on emotions, then 3 weeks just to bore you rigid on body image. And if there aren't any emotional factors triggering, then we'll probably be saying, well, we may not need phase 3 at all. If there's no body image issues, then we might say we won't need phase 4. More commonly, we need phase 4, and maybe half the time we need phase 3. So what I'm looking for is not perfection, but a shift. I want to see the eating has shifted. I want to see the cognitions have shifted. I want to see that the binging has come down, if not disappeared. So I can work out where are we going next, and I can talk to the patient about that. Most of the patients that I do this with actually buy into it really quickly. And this is where I'm going to sound a bit mawkish. I love the way that patients can feel really proud of the fact they've made a change. But they're not good at being proud. A lot of our patients really, they've grown up in environments where, pride, again, I'll talk about this a lot more when I talk about emotions, but they've grown up in an environment where expressing pride, saying, hey, I think I've done okay, is pretty much frowned on by the family, the school, the partner, whatever. So we have to be good at drawing out, bloody hell, he's done such a good job here. Really, really done well. So where we've got a good early response therapy, we're not going to be saying all the behaviors will be gone, but we might well be looking at emotional triggers, cue learning, which again will come up in the next couple of weeks, in order to be sure that the patient is cutting down their behavior. I want the eating to be straight enough before we go on to the emotions. Sometimes you'll talk to the patient and they'll say, well, yeah, I'm eating absolutely as you say, and I'm binging, so it must be something emotional. And that will trigger me to think, okay, should I start looking at core beliefs here? Of course, if the patient is eating as we're prescribing, and they're also binging, the thing you accept is weight will be going up. And sometimes you get this mysterious thing where the patient says, I'm eating absolutely fine, I'm binging lots, and their weight isn't shifting. In those cases, I'd go back and take a much closer look at that food diary, much closer look. Because it may be that the patient is giving you a bit of an idealized version. It might be that the patient needs more food to stabilize and is therefore binging to give themselves stability. I mean, I'm thinking about Cara's patient there. If you stick with that kind of received wisdom about, a woman will need about 2,000 calories a day to keep her weight stable. Well, when someone's got a BMI of 60, it's going to be a lot more calories than that just to stay stable, just to avoid binging, etc. So keep an eye out for whether the patient is actually eating enough. If not, then it may be that we need to push harder for eating, say, more snacks, larger breakfast, whatever it might be. But if you are happy, sorry, to hear a drilling noise, it's because there's a drill going off out on the ground floor. If you are happy that therapy is going well, then be really positive. Over the top positive reinforcement for what they've done so far. I think that you've done a really fantastic job. We're here at session 4. Would you have believed 3 weeks ago that you could have got to this point in this time? And the patient's expression is almost always, it never occurred to you that I could do this. Again, we're boosting their pride, we're boosting their sense of self-efficacy. That's the main thing we want the patient thinking, I can do things. I can change things about me, about the world, etc. And very often they've been brought up in an environment where that is not how they've seen the world. And of course, what we want to do is get the patient thinking, you know what, if I can do well this far, I can do well beyond this. I can go further in this therapy, and I can do things. So that's what we're really after. We want the patient thinking, hey, I did it, not you thinking that you did it or me thinking that I did it. This will come back around session 9 and 10 when we talk about how you prep people for the end of therapy, because you want them to have so much sense of self-efficacy that they know that they can get out there and carry on with life. It's great that they can get themselves out of an eating disorder, but getting on with having a life could be even more important. But the point we make here is, if you can do that well so far, yes, you can do well for the rest. That's the optimism I want to see in the patient. So I'm afraid this is a really boring part of therapy. This is the bit where we say, you know what, you're doing well. So I'll just give you an illustration of that. And then I'm going to start talking about what happens for those few people who don't do so well. And I'll show you a longer video showing how I'd handle that one. Okay, so I'm just going to switch over presentations. I will probably keep talking because I have absolutely no idea how to do this, and it's just buying myself 30 seconds of blind panic. Okay, looks okay. Right, so this is roughly what I look like doing this with Jess, and hopefully it will give you an idea. Any questions about it, save them up for the end. And any weird YouTube adverts they put in, once again, find the people who ran the damn things. I don't know how the heck this stuff happens. Right, let's play that. I'll switch myself off. Okay, Jess, it's the...
Hi, I'm Kevin McDonald. Welcome to my crib.
It's the 4th session. Now, as you know from the beginning, we've been working our way towards the 4th session to see how you're doing. Is it worth carrying on? Have you made the progress we need to see? And what I'm wondering about is, we know how you've done over the first few sessions, but how's it been this past week? Let's have a look at how your eating is now compared to what it was in the past. So any thoughts about that one?
I feel like I've done quite well. I think I've made quite a few changes. Still, the occasional thing that I should probably get better at. I'm still binging every now and then, but nowhere near as much as I was. And I just feel like, yeah, I'm eating more. I've included the oil in my diet a bit more, so I'm quite happy, yeah, with what I've been doing, but there's still room for improvement, probably.
Okay, and in that room for improvement, there may be some things we haven't actually tackled yet. So things like emotional factors, etc. I'm wondering what your body image feels like at the moment, because I know that was something that was a big concern when we got started. Has that changed, or is that still there, really?
I'd say it's still quite a big concern. I'm starting to believe you a bit more that I'm not going to put weight on massively when I eat stuff, but it is still there, like in the back of my head. I still do feel like I could be getting bigger. I've not weighed myself, but it is still a bit of a concern how I look, yeah.
No one's expecting miracles of you, okay? There's some stuff there, things like body image, maybe some of the reasons for the occasional binge still. They are things we haven't tackled yet. So I'm not expecting you to suddenly leap into being perfect. I'd be slightly worried if you did. But it sounds to me like you've made some really good progress. You've got on top of a lot of your behaviors. I'm looking at your ED15, and what I'm noticing is that a lot of the items that are about your eating, about your concerns about your weight, etc., have come down quite a bit, and that's great. I think they can still come down further, but that takes time anyway. The beliefs that haven't changed much at all are the ones about your body image, which is why I was asking about that. So, I mean, from my point of view, I think you've done a really good job. I think you've really thrown yourself at it. You've coped with how scary it is, and you've given it a real go. I can see no reason why we need to think about stopping. I'd really much rather we carried on and got on top of the remaining things that are there. Does that work for you?
Yeah, I'd like to keep going, definitely, yeah.
Okay. The only other thing I would say, based on what you said just now, is you said you're getting to the point where you believe me about your weight's not going to suddenly shoot up. What I'd really like to help you do is get to the point where you believe that yourself when you say that. Okay, so you're not dependent on me. Remember, all of this is about you need to be the one who kind of makes the big changes and feel secure in those big changes. So I'm going to keep on with that point of, we need to get you to the point where you're able to say, I don't think my weight's going to be affected by that. And you end up believing that as well. Okay. But apart from that, well done. Shall we move on to the next bit? Does that seem okay to you? Okay. Okay, so hopefully that shows you roughly what I'd be looking at in a case like this. I'll be saying, okay, you're doing really well. How do we make sure you carry on doing really well? Does that make sense to people? Any questions about that bit? Note the stuff about, look, I think you're doing really well, but we need to move it from me believing in you to you believing in you. That's a really important bit for the patient. Because otherwise the end of therapy is going to be a real mess when they're going, that's it, I'll collapse now. We've seen too many cases like that over the years. Okay, so that is a pretty boring section, and I'd be saying, right, yeah, we're now 10 minutes into the session, 15 minutes into the session. Let's do something useful with the rest of the time. As I say, it's a bit anticlimactic because you've been saying for several sessions, this is really important, this is really important. You might have been feeling anxious about it, the patient might have been feeling anxious about it, but we don't extend it. So we'll get that all done, and then we start moving on to, do we need to do more exposure, behavioural experiments? Do we need to start thinking more about the emotional triggers? Do we need to start listing out the body image tasks that we're going to be working on? I want the patient thinking, okay, past that, now let's get on with therapy, because they feel that they can make it work. That's broadly speaking all we're looking for here. What about the other cases? Now, I would say this probably happens in about 15–20% of cases that we have very limited change by this point. I'm hoping that's no surprise to you, because over the previous 3 sessions, you've been watching the patient not make much change. And as you've been paying attention to how the scores are going, their diaries, their behaviours, their weight, then it shouldn't be a big surprise that the patient isn't as engaged in therapy as they might be. Occasionally, there's an external reason. Something like my child has been ill. Okay, then let's stop therapy until you're in a position where you can use it. I don't want to punish people for the outside world getting in the way. But if the therapy interfering behaviour is something that comes from them, then I don't want to let that become the reason that we actually let therapy grind to a halt either, if I can at all avoid it. This shouldn't be a surprise to the patient either, because we've been saying to them from the very beginning, we've got 4 sessions, we'll move on if you're doing enough by then, but if we're not seeing enough change, then it's going to be an early end of therapy. And because of the degree of push you do in the first couple of sessions, you usually see people splitting. The great majority, I would say probably about 80%, will make enough change that it's a simple shoe-in kind of process. Okay, you've done well, let's get on with it. The remainder are ones where you've been aware from the last couple of sessions that this is something where it's going to be an issue. And you keep warning them beforehand. And for some of the people you warn, they really get it and they don't have a problem at this stage. But there are going to be some where they don't. It might be a motivation issue. It might be a disbelief in therapy. But there's going to be some people where there's a problem. And in order to make sense of what we do next, I want you to remember this: why stopping can make more sense than carrying on. Because we always assume if the patient is seeing me, they're doing better than if they're not seeing me. And that's not necessarily true. Again, I know I keep hammering on about it. Remember the ignoring the alarms report? Those were people who were definitely in therapy. They just weren't doing therapy. And in those cases, what you got was people who got sicker and sicker, more and more suicidal, because they weren't getting any better. The therapist was treating their turning up as being enough to say they're going to do well. Why do we do that? Again, think about human motivation. We are nice people. Well, no, you are nice people. Not me. No one's ever going to put me down as a nice person. But you are nice people. And that internal voice of yours is going to say, carry on. And you'll probably have colleagues in your service who say, oh no, we can't possibly discharge the patient. That infantilizing you see sometimes of, we've got to keep the patient nice and warm and safe, etc. Even though you're seeing them for 1 hour a week, they've got 167 hours a week to commit suicide or, not eat, etc. So we have to be responsible about, is this person actually doing enough? Many clinicians get into what's called masterly inactivity. I will bet if you think about it, you can see cases for yourself. I've certainly done it. Times when you act like, if I just keep seeing the patient, they'll suddenly click and things will start getting better. That's how come you can see a patient 100 times and they don't shift, but you can't work out how to end the therapy. Usually, you remember that scenario I gave you earlier, you've got a patient who you really wish just didn't turn up so you could discharge them. That's usually after a period where you've been doing nothing in the hope that that will somehow be effective. And we have to be honest with the patient. Look at that diagram I showed you earlier. We know that if there's not much progress by session 4, then there's very limited likelihood that this therapy is going to succeed, or that any therapy is going to succeed. Remember that diagram I showed you earlier on. Hold on. This one here is not about CBT, it's about therapies in general for all disorders. So the outcome in terms of danger is, number one, the people on your waiting list who would be, in some cases, much more willing to engage in change, could get much healthier results, but we can't see them because our books are full of patients who aren't actually progressing. There's a cost to our, let's keep things just going as they are decisions. And also what we end up doing is, if the patient doesn't engage, in change, but they do want to keep coming to therapy, they will learn that therapy doesn't work. Think about those patients who you had come along who have had multiple therapies, and all they know is therapy has never worked for them. They're pessimistic about therapy from the beginning. So it's much better to be able to say, okay, it's not that you're broken. It's not that therapy can't work for you. It's just you're not doing the therapy, therefore. And I'll give you a couple of examples. I have to talk about that in a moment. So the key thing about ending therapy at this stage, if that is what you're going to do, because remember, I will do this regardless of whether we actually end up ending therapy. The key thing is we don't want to waste the patient's time. We don't want to waste our own time. You know, I could keep you coming for years. If you're not going to change, you're not going to change. It's not going to help you. So I'd rather you step back and we came back to it when you were ready. So a bit of dialogue like we've got the one down here. You know, worst outcome would be you carry on as if you were doing therapy, but you're not actually doing therapy. Then when it doesn't work, you're going to assume that therapy doesn't work for you, you're broken. And what you can do though, is if we end therapy now, you get to learn that not doing therapy doesn't work, but the therapy could still potentially work for you in the future. So we stop now. Remember, you can come back in the future and try again when you're ready to give it a go. Now that you know what the rules are. So remember, when the patient is saying to you, but why can't I just keep going with therapy? There's a very strong chance you will learn. I'll say this directly to the patient. There's a very strong chance that what you'll learn is therapy doesn't work. And the problem is we don't know whether therapy could work for you because you're not trying it. So it might be this therapy, it might be another one, but you need to actually take part in it. That's the message I want to get across to the patient. Remember, this is a very small number of the patients, and I'm not at this stage actually trying to get the patient off my books. I'm trying to get the patient to push back. I want a patient who's pissed off enough at this happening or feels bad enough about this happening that they're prepared to actually change the behavior they've given you for the last month. That's my goal here. I'm a very sneaky human being, in case you're wondering. So you might get the patient, and we do get some of these who say, yeah, fair enough. Yep, I'm not doing it. It can't work. I know what I'd have to do to change, but I'm just not ready to do it right now. Okay, that's really good to know that you're aware of that. It would be so lovely if you came back, you know, having tried it your way. If it doesn't work, then coming back and saying, okay, I'll give it a go now, because you will know what the rules are. You'll know that we're looking for you to get going with change from very early on, not just to keep coming for weeks, months, years. You've got to be careful about going into motivational interviewing at this stage because the evidence really doesn't support it. Tends to say you'll spend another 6 or 7 sessions and get absolutely nowhere. So we're going much more behavioural than cognitive here. Josie Geller talks about this as strategic disinvestment. You know, I'm disinvesting from therapy. I'm pulling back from offering you therapy, but it's in a strategic way because what I really want to do is get you to come back and say, okay, it's not working when I do it my way. If I do it my way, which involves not changing, life doesn't get any better. You know, I don't suddenly stop binging. I don't suddenly feel better about my body. I don't suddenly have quality of life. Therefore, I'm going to stop, stand back, and try it from the beginning. And then we've got patients who don't want to stop. So this is, you know, we talked on that previous slide about the patient who says, yeah, we should stop. And there'll be a few like that. But the real group that I want to push for are those who say, I don't want to stop. My favorite line here is, I'm not stopping therapy, just you haven't started it. And that is a real shocker for a lot of patients. They're so used to the idea that the clinician will always be positive, affirming, etc. But sometimes you've also got to be honest. This is where the firmness comes in alongside the empathy. Remember, we've been trying for weeks to get this first on board with this. Now we're at short, sharp, shock territory. So saying to the patient, I would love to get you into doing therapy. The problem is not that I want to stop it. The problem is that you don't want to start it. If the patient says, I do want to stop it, and okay, then what will it take for you to actually do that rather than wanting to? You might get a patient who says, well, I can't do it now. Sometimes I'll talk with the patient about the risk. The patient will say, all right, I'll give it a try. Okay, so what are you prepared to actually do? And then you get this point of, I'm not prepared to actually change anything. In which case I'd say, okay, in that case, there isn't any point trying. Just trying to be really honest with the patient at this stage. It's about addressing that inner rescue that so many of us have. Even I've got this, it squeaks away at me sometimes that says, Ben, don't let the patient down. Some services actually reinforce this. We will always be there for you. We will always rescue you, etc. The problem is that can take away the I will learn to look after myself bit that the patient will need for the whole quality of life thing. So some services move the patient from a therapy to another or to another service, even though the clear evidence is the patient doesn't want to change. They want to be in therapy but not doing therapy. All you're doing is building up hopelessness or lack of commitment. Obviously, if there is a physical need, the patient is losing lots of weight, etc., the patient is suicidal, you deal with that problem. But you don't pretend that this, putting the patient into an inpatient unit for a while is going to solve the problem. It's an interim step for dealing with that specific problem at that particular point. What I don't want is a patient who's hopeless, who lacks commitment. We use that strategic disengagement to get the patient to chase us to actively engage. If I walk away from offering the patient therapy, they then have to actually take an active step towards coming back and pushing to get back into therapy. I want that. I want the patient saying, all right, what do I have to do? If we don't do that, though, we end up with all the immobile cases and a lot of people on the waiting list who could do well. This is what I'm really looking for, the patient to ask for one last chance. If I can get that from the patient, I've got something to work with. Now, it won't work every time, but it is something that I've seen work enough times. I'd probably say about half the time that we've done it. This will be an effective technique for getting the patient engaged and actually change. So, session 4, patient says, oh, please, can I just have one go? I didn't know you really meant it about the change. At that point, I'll say, well, look, I can, if you like, stretch it and give you one more session, but you would have to make huge changes over that time. Essentially what I present with is, I need you to do the last 4 weeks worth of work in a week. Are you really up for that? If you're not going to do it, there's no point in taking an extra week. And occasionally you get patients say, no, I don't want to actually change. Okay, then there's no point carrying on at this point. But I also get patients who actually do push for, well, look, give me a try. I'll make the change. I'll eat the food, etc., etc. They're the ones I want to give a good chance to. Like I say, my goal here is not to kick people out of therapy. My goal is actually to get people from being in therapy to doing therapy, if I possibly can. And the thing I'll do at that point is I'll say, okay, look, we're 20, 30 minutes into the session. I'm going to stop here. If you're going to do it, you need to get out there and start eating differently. Start changing your pattern of behavior. And if you're not going to do that, it's not going to work. So rather than have you talk to me for another 20 minutes, I'd say it's much more important that you go out there and start getting back on track with your eating. Of course, what I will then get them to think about is, what exactly are you going to change? So I think you'll see this in the video that I'm going to show you, but I'll get the patient saying, yeah, I'm absolutely prepared to give this a go. I'm going to give it a go. Okay, so let's imagine I'm talking to Joe there. Joe says to me, yes, I'm really, really going to give this a go. My reaction to that is going to be, okay, so we'll end therapy at this point. What's the next thing you're going to do? I'm going to go back to work. Okay, that's not going to be effective. Joe, what you're going to need to do is go and eat the breakfast that you missed 2 hours ago, and then have your snack, and then have your lunch. In other words, it's not a get me out of this room with the promise of coming back. It's I need to get out of this room, but I've got stuff to do. And part of our job is to get the person thinking straight away, act now, or it's not going to work. So that, broadly speaking, is what I'd be looking at doing. I want to get the patient to that point where they're asking for that one last chance. And it does feel like pleading sometimes. It does feel a bit embarrassing, but if they'll do it, that's showing motivation. And that's really what I'm looking for here, motivation to change. Will they use it? I'd say about half do. And it always astonishes me because I'm no good at predicting who's going to do it. I've had patients where I thought, no, you're never going to go near doing this. And they come back, yep, here's my food diary, this is what I did. Then other people I thought might give it a go, haven't done it. Again, I'd say it's about 50-50. But by the time they've not done it for a week, those people are generally more acclimatized to the idea of actually, there's no point carrying on here. The ones who, of course, say, yes, I'll do it, but then aren't prepared to actually change their eating, I wouldn't even bother with session 5. They're just keen to stay in therapy, not keen to do therapy. So how do we deliver the bad news of, actually, that's it, we're going to stop. This is where you need the firmness and the empathy both played at high volume. I want that patient thinking, okay, I really do want you to do well in therapy. I want you to get your life back. But the non-engagement is the problem. It doesn't have to be that way, though. You know, the fact that you're not engaged in change now doesn't have to be that way. You know, I warned you before we were going to end therapy early if it's happening. And you know, essentially, we're doing what we promised, but it doesn't mean that you can't come back. I always want to get across that idea of, I really believe you could do successful therapy in the future. I want that patient thinking, okay, there's a bit of optimism about this. I could go back. We keep a track of people who we've done this with. The great majority come back for a second go. So we don't think we're putting them off completely. We think we're giving them what Josie Geller talks about, strategic disinvestment, which means they've got no one to fight against anymore. You know, Josie Geller puts it as, you know, I haven't got my therapist to fight anymore, and shit, that means I've got to face that this is about my decisions, not about, you know, I can't do it because. So I'm going to take you through what that would look like. You know, running a longer video this time, because I want to make sure the patient really gets that I mean what I was saying about I believe they can change, etc. So let me just get back my second. Yep. Okay, so I'm going to run the next bit of video. Hopefully I've got the right thing here. Boom, boom. I think I've got it now. Okay, so let's play this. Like I said, it's about 10, 12 minutes. So we'll do a little bit after that, then coffee, because I think you deserve it by now. I'll turn myself off again, and I'll see you again shortly. Okay, Jess, it's session 4. Now, YouTube videos. This is the review point that we talked about. I know I was stressing it to you last time and the previous times, but particularly last time, because you had gone a bit off track with your eating, etc. And I wanted you to try getting back on track with your eating, getting back on track with your diary, and adding in the butter that we talked about putting into your diet. So what I want to know is, have you got back there so that we can see a way forward with the therapy? So over to you. What's the past week been like?
I've really struggled, to be honest. I've not been on track as I should. I've skipped meals again. I felt quite down about it, which was just like a a cycle of just not eating again and then binging. I just don't want to put the butter in my diet. That still just is too scary. So I've not done that. I feel like I've just found it really hard and I've not really made any changes.
Okay. Is there a reason for that? For that kind of staying off track?
I've just found it too hard, too scary. I just feel like there's a different way to change it. Like just focusing on my emotions maybe would just make more sense. I just don't want to change my eating, I guess.
Okay. And has that focusing on anything but the eating worked in the past?
Well, I guess I'm here still. But
I think it's just important. I totally understand. People want there to be some kind of almost magic cure, something that will make them think, okay, I can do this without having to put in the effort. Problem is, based on all the evidence that we've got around this stuff, there isn't a magic cure. I mean, if there was, I'd be dispensing it like a shot. So it was a case of waving the magic wand and everyone got better. I could think of other things to do with my time. I would have no problem with that at all. Unfortunately, there isn't. We haven't ever seen that. We know that the change that you need to make is going to be behavioural. It's going to be hard work, and we know that the emotions matter. We just know that we can't get them changed until you're biologically stable enough for that to work. Okay, so it sounds like we've stayed off track now for a couple of weeks. I've talked to you about the importance of getting back on track, 2 weeks straight now, and you haven't done it. As I said at the beginning, this is the point where I need to be thinking, is there any point in this carrying on, or am I wasting your time? Am I wasting my time in trying to help you in something that you're not going to do? Have to say, some people don't want to do the therapy. So nobody's saying you must do the therapy. This is an opportunity, as far as I can see, for you to get well. If your option is to say, you know what, it's not important enough for me to do it right now, you might say, I'll come back another time and I might do it then. But I can definitely guarantee the rules will still be the same next time round. I don't think we'll come up with a magic wand between now and when you next want to do something about this. I mean, the disappointment from my point of view is not that you haven't done it this time, but that you might come back in 3, 4, 5 years' time saying, okay, I want to do it now. And that'll be 3, 4, or 5 years of your life that will have gone pretty miserably. Again, that's not me saying, you must do anything. You've got to choose. So at this point, normally I would be saying, you know what, I think we should stop. I don't think there's any point in carrying on. You're not doing the therapy. You're not taking the advice. If you went to the doctor and said, I want to clear up this chest infection, and the doctor gave you pills and you didn't take the pills, the doctor's going to be sitting there going, well, what do you want from me? And I think we're in that kind of position right now. The only way in which I could see you benefit from therapy would be to get right back onto it immediately, not saying, oh, in a couple of weeks, maybe I'll try it. You'd have to go back and you'd have to make up the last couple of weeks as well. So you'd have to not just get onto eating regularly, not weighing yourself, keeping a diary. You'd also have to, do the added foods, the butters, things like that, just to have a chance to catch up and get onto the emotional and the body image stuff. And that's really hard work. No one's pretending it's not. It's hard work because you haven't done the last couple of weeks of it. It's harder work because of that. It's always hard work. So I need you to make the active choice here. Is this you saying, I'm not doing it? Or do you want to give it one more try for one more session, and knowing that you're going to have to make all those changes really fast, by next week, in order for this to be worthwhile? And I don't know what the answer to that one is. So Jess, it's over to you.
I mean, that does all sound pretty horrendous, but I think, like you said, like trying again in 5 years' time and just like having those 5 years just miserable sounds even worse, I guess. But I think, yeah, I'd like to do the next session. I will make changes. Really don't want to start all over again.
Okay. I think, I don't mean to be pessimistic about this, but I've heard people say this before, and sometimes they come back next week having done a bit of it, or they come back saying, I've tried, and trying won't cut it. As I said to you last time, the word trying is usually a fairly kind of, it's one that people use when they haven't actually made the change. I would need to see you making a whole pile of changes, and that's commitment on your part that I don't have any right to demand. I'm not demanding anything. It's your opportunity to skip those next 5 years of being miserable. If the therapy works, I can't even guarantee the therapy will work. That's how bad a deal I'm offering you. But I can guarantee you the miserable 5 years if you don't. But okay, so I can be sure that you actually mean that you want to give it a try, that you're going to actually make the change. Can you just tell me what you'd be committing to doing by next week? I want to be sure that you've got the sheer depth of it in your head. What would you be? What would you look like if you came back to session 5 and you knew that I was going to be saying, if you haven't done it all, then that's it. So what would it look like?
It would look like eating my 3 meals a day with my carbs, getting my snacks in, which I know I've struggled with before. I won't weigh myself. I'll make sure I keep my diaries. I'll just really try. I'll cook with oil with all my meals. I'm willing to do it. I really don't want to do this for another 5 years like this.
What is there about today that's making you say that you'll do these things when you haven't done for the last couple of weeks? What's different?
I guess I was almost expecting you to just say it's okay and we can just focus on something else instead. So I was a bit surprised when you just said it's this or we can't do it. It's just made me realise that I have actually got to change and I can't just wait for something else to happen.
On a kind of 0 to 10 scale, how anxious are you about trying to make these changes?
Like 10, I'm really anxious, but I just, like I said, I think the alternative is just way worse for me at the minute. I really can't be doing this for much longer. I really will change, and I'll do it within this week, and I'll show you that I can do it.
Okay. Well, honestly, I don't know if you will. I absolutely believe you can. I don't know whether you will. So now what we're in is the point where you've got to prove it. Obviously I'm a sweet and lovable guy and all that, but there will come a limit. Well, no, I'm not. I'm a pain in the neck. I know I'm a pain in the neck. I'm fine with that. But I believe that you can do it. You've got to show that you will do it. Otherwise, there won't be any point going past the next session. We'll stop then. The reason for this is, pretty much as I said at the beginning, if you get all the way to session 10 or session 20 or session 40 or 50 and you haven't started making changes, you haven't made the big changes, you're going to end up therapy thinking therapy doesn't work, or therapy doesn't work for me, or I'm broken and can't be repaired. If I can say to you now, it's not going to work because you're not doing it, that gives you a bit more option, because this time or next time or the time after, whenever you decide that you're actually going to do it, and I'm hoping you're right, I'm hoping it'll be this week, at that point, there's still a bit of you that says, well, I never did the therapy properly before, so let's see what it's like if I try doing it properly now. Does that make sense?
Yeah, and that's how I'm feeling a bit more now. Like you said, I've been in therapy before and it's not worked, but this one's different. Like I said, I wasn't expecting you to just say we can't do it. So it's clearly like different to the other ones. So if I need to try this week, I'm going to do it. Yeah.
I really hope so. What we'll do in that case is go over what you have done so far, and we'll plan out what you're going to need to do by next week. And I'm probably going to end this session early because there won't be much more to talk about, but there will be a need for you to get out there and get started. So, for example, it's 10 o'clock now. What did you have for breakfast today?
Didn't have breakfast.
Okay, so if we finish at 10:30, what's the next thing on your agenda?
Be having a snack or my lunch, I guess, an early lunch.
I'd say no. You're already dropping down. Your next step needs to be have the breakfast that you missed, and then catch up with your snack, then catch up with your lunch. The thing people often do is they say, "Oh, I blew it today," or "I blew it this morning. I'll pick it up again later." That never works, because by the time you've given yourself enough excuses, you're back into the position you're in right now. Okay? So, like I say, I believe you can do it. I need you to convince me that you will do it. And if you're sitting there thinking, he's a real pain in the backside, then show me that you can do it, and I'll be the happiest bunny alive. But until that point, I'm going to be saying, okay, next week might be the very final session. It might not be. I'm hoping it won't be. But I see no point in extending the therapy if you're not going to start making the changes. Okay. We know you can. You did it the first session or two. I know that you can do it now. So I'm hoping, like I say, you will. Okay, so we'll go over what you were eating this week. We'll look at what went wrong. We'll look at why you binged, and then we'll end early, and you can get off and have the breakfast that you missed. Okay.
Yep.
All right. Okay. So let's talk about the other stuff. I have to say, it's incredibly tempting at that point to be thinking, brilliant. Yep, she said she's going to do it. What I'm doing is laying down, okay, now prove it. Point where she's got to push and getting her to make the case that she's going to be doing it during the session. Because if she's not actually going to do it because she's just hoping to get out of the room and feel comfortable, then let's not waste her time. So I'm deliberately trying to get her to come along and push for, yeah, I'm going to do it. I'm going to do it, Glenn. I'm going to do it. Because I really want her to do well. But I need her to be motivated as she goes out of the room. So hopefully that gives you an illustration. And now hopefully you can see what I'm going to be asking you to do as part of the skills practice later on. What I want you to do is skills practice later is to try out running that for yourself. Have a couple of sessions, one where the patient has done well, one where the patient isn't doing well, and make sure you give plenty of time for that one. Because I want you to walk away saying, okay, tried it out, I've seen it happen, I've tried it in role play. So at some point you're going to need to do that with a patient. And if you can do it and get the patient coming back next time going, actually, do you know what? I did make the change and it does feel better. That is such a nice feeling. So good, because it means you can pick up and move on. Any questions about that? I know it's one of those bits where people go, can you really say that? Can you do that sort of thing with the patient? But are there any questions people have got at this stage about what you just seen? No. Okay. So what we will do now is we'll carry on. We'll work on the basis of the patient does buy into it, or the patient is already buying into it, and that'll cover 80, 85, 90% of the people you're working with. You will carry on to session 5 and 6 and 7, etc. Remember, the attrition rate is quite a bit lower here than it is for CBTE. I think possibly because you can't drop out of session 14 if there's no session 14. But we do know that we keep people pretty well. And I want you to be good at that. I want you to be good at keeping people on board, but keeping people on board as active therapists. So what we're going to do now is we're going to take a coffee break. We're going to come back at 10 past. In fact, no, after all, I'll put you through. Let's come back at 1/4 past, okay? Come back at 1/4 past, and it'll be behavioural experiment time. Okay? Have a good break. I will see you shortly, folks. I'm going to turn off the recording right now. And if you think of any questions you want to ask when you come back, feel free.